a few years ago, when this place was built, what was it called? It was called El Camino Hospital, right? But no, then a few years ago, and very appropriately, they changed their name to El Camino Health. And why is that? And the reason is, as I say, they so seriously now take this whole concept of continuum of care, and that includes getting out into the community with education, with wellness, and trying to instill that early on. And then equally as importantly is after patients are here in the hospital, whether they have a procedure or whatever, continue to manage them and help them. And that specifically for cardiovascular disease is an incredible cardiopulmonary wellness center that we have 3 rock stars here that are going to explain. First and foremost, Julie Arbuckle, who you already heard mentioned several times today, manages the Cardiopulmonary Wellness Center. And Julie, so honestly, Julie I think is one of the few people in the room who's been at El Camino longer than me. She always reminds me that. 33 years. I'm 32. And I always tell her she started in high school, so she had a jump start on me. But no, and she has had an amazing career at the institution. She was in the emergency room. She's worked in the ICU. And for the last now 12 years, I want to be careful, I quote appropriately, 12 years, she has directed this incredible wellness program that we now have at the hospital. Seated next to her is Dr. Puneet Sarna, who is a clinical cardiologist, so fully trained in clinical cardiology, but then he even took a little extra step and he spent some time as a specialty in congestive heart failure. So we, again, are very privileged to have a congestive heart failure specialist, and he and Dr. Ahmad oversee, are medical directors of our heart failure program here at the hospital, do a great job with that. And then last but certainly not least, my dear friend, Dr. Neil Scott, who, like me, is a long-timer here at El Camino. Not old, you're just a long-timer. Right? Isn't that where we are? No, honestly. So Neil is my partner and has been my partner for quite a few years. And so Neil not only got an MD at that Stanford wannabe school back in Cambridge, I think it's called Harvard, but he spent a bunch of extra years getting a PhD. So he brings to his patient care an extraordinary amount of intellect and academic science-based approach with his patients. But not only that, he injects an extraordinary amount of compassion and empathy and really is a model for how all of us should be cardiologists. He's been an amazing person, amazing player in our community for years, and I can't thank you enough, Neil, for all you've done for all of us here in the community. It's really been wonderful. And he also helps now run with Julie the cardiopulmonary wellness. So, Julie, take it away. Thank you.
Okay, well, that was sure a hard act to follow. Carol, you should get the Academy Award.
That's right.
And it was a pleasure working with you. Our team just loves you, so thank you for taking time out of your Saturday to share your stories. It's pretty amazing. So we have the last part of it, which is medical cardiology, and it doesn't sound as sexy as all the other ones that came before us, but sometimes medical management is just as important as having procedures. So I'm going to start with a scenario of Mrs. Jones, and she has a history of high blood pressure, she has high cholesterol, and she also is a little bit overweight. So it's kind of a typical patient that we see in our population on a daily basis. So she has been experiencing increased shortness of breath and fatigue over the last couple of months. In the last 2 weeks, she's noticed that she's had some lower leg swelling, mostly in her ankles and her feet. She knows the importance of exercise, so one day she goes out for a walk and she becomes extremely short of breath. She just can't get any air in, and she ends up in the emergency room. And Dr. Sarna, you get called and said, we need you to come and do a cardiology evaluation. So take us through your process and how you might medically work her up.
Sure, absolutely. So very typical presentation. We get that call multiple times a day, and every time that presentation is made, you're organizing your thoughts around how sick is this patient? Is this somebody that is in some form of distress? Do they need to go to the ICU? Do they need a more emergent procedure? And you heard earlier today from both our electrophysiologist and our interventionalist, we need to know early on, do we need to pull those folks in? So some of the tests that are already being done in the emergency room are helping navigate that. Some of the blood work, you heard about troponin markers, if there's some injury to the heart. The EKG may sound simple, but is actually really informative. Is this somebody that is having some ischemia, some heart blockage? Are they having a rhythm problem? Could Mrs. Jones be having AFib? Or has she had a heart attack at home that she didn't recognize and now is coming in with some new onset heart failure? And so, assuming that things are stable in the emergency room, we come in and we want to get a chance to meet her, examine her, and get a gauge on where she is on that spectrum of urgency. And based on some of those tests, we may order, as you've heard earlier today, additional tests such as an echocardiogram to look at her heart function and see if the valves are working okay. How is the heart squeezing and relaxing? All of those are tests, those maneuvers are going to start to paint a picture of what's going on. And then based on that, we can start some treatment. Sometimes it may be as simple as some diuretics to help get some fluid off. But we really want to have a deeper understanding of why she's coming in, what has started to not work well. And it may actually just be something as simple as hypertension that wasn't treated, but it could be something more complicated. And so that would kind of be the initial approach until we get a little more of an in-depth understanding of what's going on. It's also an exciting time to do the maybe not so sexy medical cardiology because the medications that are available are, I mean, truly life-altering. And you can, I mean, I see a few of my patients here in the audience today and hopefully at home as well. They'll tell you, I mean, the entire list of medications that have come through that are truly shown to help extend life, to reduce mortality, it's just amazing. So it's an amazing time to confront these challenges. We always want our patients to know that, you know, we're there with them. We want them to get the best treatments, the latest technologies that can help. And that's not just the physical procedures, it's also the medications, but then also a lot of what we do in cardiac rehab and hopefully altering the trajectory of their life going forward.
So anything to add?
Well, one of the things we always look at in our patients is once they get close to discharge or once they're out of the hospital, how do we keep them from coming back into the hospital? And that's the importance of cardiac rehab. So if you have a prior diagnosis, like in the hospital, of a heart attack or a stent or valve surgery, or a new diagnosis of a type of congestive heart failure where your squeezing is not as good as it should be, then you're eligible for cardiac rehab. And there, what we will do is teach our patients how to change their lives. We stress the importance of exercise. We stress the importance of an appropriate diet that is either a Mediterranean diet or a predominantly plant-based diet. We teach stress reduction so that, and it's, as you heard, it's a pretty intensive program of 3 times a week, 12 weeks for the whole session. So again, the whole goal of that is to change the course of people's lives so they live healthier, they're happier, and are less likely to be admitted to the hospital. And Julie has been phenomenal in running that program day to day.
Well, I'll elaborate a little bit on cardiac rehab. So any patient that comes through our hospital that's had any of the interventions that you saw today, they get an automatic referral to cardiac rehab. So I can't take all the credit. I have a wonderful team of exercise physiologists and nurses that work alongside with me that really do make a difference for patients. We're very big on lifestyle. Back in the day, cardiac rehab used to come in, it was just about exercise, and then you would leave. And what we would see is the same people were coming back, and it was like, what are we not doing right? And so what we've done is we've really turned it into lifestyle medicine. So we really emphasize it's not just what you're doing with your feet. We know exercise is important, but we incorporated a food as medicine program. So we have a full-time dietitian. We're very fortunate to have her. And she does a really great job on educating our patients about a plant-strong diet. And she does cooking demonstrations, and she gives them recipes, and they really get an idea that what you put in your body really does make a difference in the longevity of how long you live, and it definitely affects your heart. And then I have a great nurse, Karen, which Carol talked about, and she does our Stress Matters program. And we know stress is a huge component of cardiovascular disease, and we work on techniques of actually how can we identify your personal stresses. We do mindful meditation, we look at self-care strategies, and we even throw a little bit of laughter yoga into our program, and the patients really love that. We've also incorporated strength training because we know that's an important part of your overall fitness, and it really does make a difference in your glucose. And I know they mentioned it earlier, we don't want high blood sugars. That's not good for our body in general, and it's definitely not good for our heart. And then we work on balance. You know, it's not just the 80-year-olds that fall, but younger people can fall too. So it's really important that we engage everybody in balance and core training. So we really have like I said, a lifestyle approach to how we do cardiac rehab. And as much as our patients don't want to graduate, at some point we do have to push them out the door because we hope that the time they spend with us, they have the tools that they need to continue what they learned in the program and take it outside, because our goal is to get them independent. We want them to get back doing the things that they were doing, like Carol said. It was just making a bed or going to the grocery store. So we really try to individualize it to our patients as well. Like, we want them to meet their goals, their personal goals. And I mean, I think that by the time they graduate, I always give the description when they come through the door on their first session, they're like a hummingbird. Their eyes are like, and when they leave, it's like an eagle. Their wings are spread, and they like fly out like an eagle. They have the confidence they need. They've got the tools that they need. And then hopefully we don't see them again.
We get to see them in the office afterwards, and it's day and night. I mean, they really come in, and they're different people. They are, I think the confidence, the self-esteem, it's back, and they're moving forward. Yeah, so we definitely see the difference.
So let's turn it over to questions, and not just in the room, but also Zoom, Kathleen. Anybody have questions? They're coming.
Thank you for the program. Anyway, that was very interesting. My question is regarding lifestyle. We are individuals close to 80s, and we still like to take long transatlantic travels. We are facing another trip like that in 2 weeks, which means taking a 15-hour flight to a continent which is 9 hours ahead, and everything is different. My question is, would you suggest anything one should do to sort of prepare oneself for a trip like that? Especially since one of us experienced on the visiting trip here, a heart attack on the plane that happened on the flight to America. So we would not like to happen anything like that to us. So maybe some things that we should know that we don't think about. Thank you.
I think the easiest answer for that is to discuss this issue with your doctor, who's aware of your particular problems, issues, and can address whether or not you should be, what kind of medicines you should be on for such a long flight, if any. And that's probably the best way to go, is to talk to your doctor.
So basically, you think it would be a good idea to see a doctor before the trip?
To see your doctor?
Yes.
Yes. Mm-hmm.
Okay.
So I'll chime in. I think I saw you guys walk in. You look like you're pretty active. So I think that the trip is going to be easy for you. But I would encourage you to get up out of your seats when you're on the airplane, because blood tends to pool into the lower extremities. You want to make sure you're getting up and moving around. But I think you guys look like you're ready to go. You only live once, so live it good.
Is this on? Yeah. So Julie and you guys, just a quick question here that I frequently hear the comment, I would like your guys' opinion on it, that we all know that when we pass away, we will have some degree of cardiovascular disease. Nobody gets out without any. The question is, and we also know that it's the greatest killer around the world, but what do you guys think about the concept that it really is optional? Are there things that we can specifically do to be absolutely sure that we do not have a terminal event from cardiovascular disease?
Well, I'm going to tell you there's no guarantees in life. So I've seen people in my cardiac rehab program, they walk in and I think they've found the wrong place. They don't look like they had a heart attack. Their weight's perfect. They look super athletic. I mean, we know heart disease, covers all age groups, all ethnic races. I think there are things you can do preventatively to help, and I think regular exercise is huge. I think getting sleep, controlling your stress, weight management, and then I'm a big component, get together with people. I mean, COVID didn't do us well, but we are human beings, we're social. We need that social interaction. We need to find those people that make us laugh. We have so much seriousness in this world today. We just need to find a little downtime and just really enjoy life.
I'd just add to that, yes, indeed. Along with what Julie was just saying is truly like understanding what are the things in your life that you can control. What can you change? I talk to patients, Dr. Scott and I both talk to patients at length about their lifestyle, about their diet. And, people say, hey, no one ever jumped up out of bed excited to go see their doctor, but they come in and oftentimes it's a serious matter. They're worried about what they're contending with. They want to know what they can do to reverse that. And oftentimes it really is the simple things that can have the biggest impact. Your diet. But I think a lot of times patients may not, we don't do a great job of telling people. Marketing campaigns really kind of skew our thoughts on wellness. And I'll give you an example of, Dr. Scott mentioned a plant-based diet. A plant-based diet is a wonderful way. I haven't met anybody who couldn't benefit from that. But if you tell somebody you can't eat this, this, and this, and this, and then they kind of look at you like, what do you want me to do? And we want to show them that, no, there's a whole wonderful plethora of things that you can do. We're eating every 4 or 6 hours. And if you're eating for your wellness, oh man, that can have such a huge impact on everything else. And that's just one aspect of it. Staying on top of your medications, that can also really add a lot of value to your health, your recovery, and avoid problems. So I think that there is this theme that you've heard today through several of the speakers of lifestyle, of wellness. we have different departments, but honestly, it is a very comprehensive approach to your health, your well-being, your longevity.
Yeah, and oh, you have a question.
Sorry.
There are different guidelines for diet for my 3 favorite health foods: dark chocolate, red wine, and coffee. So do I have to limit, or, because I was drinking, honestly, red wine, half a cup every day, because now it's down to two glasses for women. So what about those?
The dietary recommendations, or the recommendations for those 3 substances, are so controversial and are under a constant state of flux. Almost every year or two, there's a huge study that's published that shows that coffee is good for you or it's not as good for you. The same thing with alcohol. We were taught during our training that 1 glass of wine for women, 2 a day for men, is great and decreases your mortality from cardiac disease lower than those people who don't drink. And dark chocolate, up and down, off and on. And nowadays it's shown that with alcohol, for instance, yeah, maybe your cardiovascular risks may be lower, but your cancer risks are higher, and cancer deaths are higher. So it's really controversial, and I don't think any of us can look at you and say, this is what you need to do, unless we're talking about today, based on today's data, which may change tomorrow.
Similar question, except the cholesterol content in egg yolk. And whether or not it's,
How much time do you have?
benefits and risks, right?
A lot of controversy on that one, too.
Who's paying for the study?
Okay, the question is, what about eggs and their cholesterol content? Is that good for you? Is that not? And again, data there are very controversial, especially since the egg issue is more complex because a lot of the studies were sponsored by the egg industry. So we don't know what to believe. So I can't look at you and say, eat 3 eggs a day. I would not tell you that, but I'd say, yeah, I'm going to reserve my opinion.
I think that there are probably better things you could be eating in place of eggs that are going to add value to your health and hopefully also avoid some of the detrimental effects. Some of the byproducts of egg metabolism are not good for us, and we know that's true. But Dr. Scott is right. Who's paying for the study makes a big difference on the results.
Thank you.
Yeah.
We make a lot of issues, and we hear about it all the time. You're rehabilitating people with their diets, lose weight, get healthy. How do you handle somebody who's gone through a series of health problems, has lost 50 pounds and needs to put weight on?
Well, you come see my dietitian named Sherry, and she will help you with that. There are people that actually do need to put on healthy weight. And some of that healthy weight would come through strength training, but also in diet. So it's getting back to some healthy fats. There are healthy fats out there. And yeah, I mean, there's ways that you can put on weight, and I think that what we try to do is individualize it to the person. So I would say, I also run the pulmonary rehab program, so I have those issues with pulmonary patients because they're spending so much time breathing, they can't eat, and so that becomes a problem. So your meal wants to be as calorie conscious as possible. You want to get the most calories you can that are healthy the times that you eat. So yeah, it's a tricky one. Most people would love to have to gain weight, right? But they don't understand the other sides of it, which is sometimes it's difficult.
Many places nowadays we see these defib machines lying there, like in the gyms and other places, and it's more and more common. And not everybody may know how to do CPR at home and stuff like that. So for situations where you know, like my parents, they have heart issues, known heart issues. Is it now advisable to keep a defib machine at home? Because if something happens, CPR may not be possible immediately. And like,
Yes, we've got electrophysiologists. We have electrophysiologists here.
Well, I mean, yes. I mean, it's always knowing CPR is obviously the easiest thing. Yes, I mean, knowing CPR is obviously the easiest thing, and certainly advocate for everybody. But you know, defibrillators. Yeah, I think in high-risk places, high-risk situations, in a gym, airports, these places all benefit from that. I mean, I think if you had someone who's predisposed, like we talked about earlier, with some pre-existing heart disease, yeah, I think it's very helpful. And nowadays, the defibrillators have their own smarts built in. You actually don't have to know much to use it.
So let me add to that to keep your eyes open, because we're working on a project for a very inexpensive, very, very small defibrillator about the size of basically 2 little iPhones that has connectivity. And so I think the defibrillators in 5 years will be really very widespread. And the most important thing is to know how to use them and when to use them. And so that we'll all need to embrace that part of our education.
Okay. Thank you.
Thank you.